Hello everyone, this is Shadi Reis from CVI 2023. I'm really privileged today to be with Dr. Manoj Thangam. He's one of the interventional cardiologists here in Dallas, Austin. We're in Austin, and we're going to talk about VTE therapy and catheter-based therapies. Manoj, also nice to see you.
Pleasure to be here. Thank you for having me.
Thank you. So your talk was talking about, in general, about VTE management. The speaker before you was talking about PE, and I think we have kind of enough evidence for the PE. The vein is, and deep vein especially, is people are not as skilled, so they're not familiar either with the toolkit or the indication. So let's talk about some background of the topic.
I think it's a very fair point. I think it's a little bit of no man's land.
Yeah.
It's very little clinical trial level data. For deep vein thrombosis, in the context of acute deep vein thrombosis, we really have one of the primary hallmarks being the ATTRACT trial, and then we had a follow-up to the ATTRACT trial that was 2 years later in 2019 that came out in circulation. Ultimately, those trials were asking the question that if you went in and did invasive catheter-based therapies, primarily based on thrombolytic therapy, if there was any benefit to having a decrease in post-thrombotic syndrome. The synopsis is that no, you don't decrease post-thrombotic syndrome by doing the procedure. Obviously, you have a slightly increased risk of bleeding by a procedural access and the fact that you're giving localized lytics. However, in a subset of the population, which is really the focus of what most of us really do deep vein work on for DVTs, is amongst patients who have thrombus in their iliac vein or in their common femoral vein, not just in their femoral vein or POP or anything below, because that doesn't seem too clinically relevant in terms of actual practice and data that pans out. Amongst those populations, you don't prevent post-thrombotic syndrome, but if a patient were to have it, you have a less severe incidence of post-thrombotic syndrome based on objective scoring systems. And then secondarily, you have much better symptom improvement within the first 10 days than you would otherwise, so there's significant improvement in quality of life in the beginning.
And this is regardless of what type, is it provoked or unprovoked, any type of
this is all-comer deep vein thrombosis.
Okay. So what kind of tools we have now on access site?
So the primary kind of modalities are usually the two workhorses being the ClotTriever device that exists with the Inari platform. They have the regular ClotTriever, and then there's the ClotTriever Bold that has about a 30% increased tensile strength. And the theory behind that is to use that in more kind of subacute picture clots, with the acute definition being 2 weeks for a thrombus and subacute being greater than that. And then you're going into chronic kind of deep vein thrombosis, which is a whole different bag of worms to kind of get out. Just to kind of lay a foundation for it, the reason for that is because when you look at clots in and of themselves, you have an acute clot, and most of that is actually just platelets that are adhering to one another through cross linkages. After you get through the 10-day to 14-day time range, most of that is turned into collagen, and after the 14 to 21 time range, you end up getting most of that as just acellular, extracellular matrix. So it's just glue. So you're working in clot that you can pull out here, or you're working in glue that you can't. And that's kind of an important distinction to make why acute is a great time to do it if you're going to go do it. And then the other workhorse is penumbra, which is coming out. Both of the accesses for these tend to be from the popliteal. You can do it in other ways. I've come in from the IJ. You can go up and over. But the issue here becomes veins have valves.
Yes.
And valves that are in clot are especially resistant. So you're going to have a very difficult time pushing through those valves when you're going against their grain functionally, as opposed to when you're coming up from the POP, you're pushing the valves open. Nice. You're not trying to crack a valve open to the opposite side of where it's supposed to oppose to in a clotted structure. Right. So that becomes a much more difficult thing to do oftentimes.
So basically on the background you mentioned earlier and the window, so the window for therapy is really narrow. Yes. And as you said, the data showing that post-thrombotic syndrome is hard to predict, but yet we don't want to wait too long, because if it's just getting calcified or organized, it's going to be hard to pull. So early intervention sounds more the way to do it, especially if in common and iliac vein.
I think that's right. I think in our practice, what we do over at the Dell Medical School and the Ascension Texas Cardiovascular System is we kind of try to protocolize this, and we do this the same within our group. And when we do it, we really do it for patients who clearly show that they're severely symptomatic already, like patients who can't weight bear on the leg, who have severe pain even without movement or ambulation or anything like that, and extensive clot. and usually with color flow Doppler showing no flow, so a full occlusion. There's partially occlusive or completely occlusive. In this case, they're fully occlusive. And in that scenario, we think it's a pretty kind of grand slam situation to go after it. And doing it early, like you mentioned, is exactly the right thing to do in that scenario, because if you wait, what you're going to end up doing is you're not going to get clot out, which ultimately is okay if you restore inline flow, but it's very difficult to restore inline flow after that transition point. Because everything is glue. So the recoil through these vessels has gotten to basically what we worry and what we get into difficult situations in critical limb ischemia and such with recoil on those vessels, especially below the pop, you know. It's kind of very similar in the venous system.
In terms of medical therapy after your intervention, is it the same thing in terms of agent use as well as the duration?
Yes. With the duration, I guess, being clarified, so I prefer NOACs, obviously, like everybody else does, for ease of use as opposed to warfarin. Some gray area if you have, antiphospholipid syndrome particularly, that there may be a discussion to use something else. But even then, there have been patients who have elected to be on a NOAC and done fine, understanding that there may be a slight discrepancy on the data for best outcomes there. But duration, I think, is an interesting question, because there are people who vary widely across the country, whether they're in cardiology or they're invasive cardiology or if they're hematology, on duration of therapy, with some people doing short durations of 3 months, some even a little shorter, to people who are doing 6 months. And I think if you have a severe symptomatic clot, especially like if you have a concomitant, with a lot of the times we'll have concomitant PE as well, we treat those, I usually will do 6 months of therapy unless they have a darn good reason to stop. If they can tolerate it, I'll do a full 6 months of therapy, and we'll kind of go from there to pick up. Throughout that 6-month period, I'll make sure that they have a hematology evaluation for a hypercoagulable state, and we'll also see what their new fingerprint's going to be. And what I mean by that is we will see what their venous system looks like with repeat ultrasounds with flow Doppler, so that we can see
flow and
for restoration of flow, and also to see what's residual thrombus. It would be false and inaccurate for people to believe that going in and doing a device is going to pull out all of the clot. There's absolutely clot that's going to be left over, especially in scenarios where you've gotten it late. You have patients coming in a month later who just have severe pain and still have an occlusive clot, and you have to go do what you can. And very rare scenarios where you have like phlegmatia, right? Like if you have phlegmatia cruella deruens, it's a terrifying scenario where that leg is going to be an acute situation. You're going to go in and do whatever you can, from dripping lytics and so on and so forth. But after you've gotten through these acute processes, I give them their full dose anticoagulation duration, usually 6 months. And then at close to that end point, I'll repeat the ultrasound on the leg to see what now we're going to judge it against for the rest of their life.
Last question about stenting. When do you think you need to stent the iliac? And
that's a great question, and a question that's exceptionally controversial, which I love. I do, because I think the reality is that the jury on that is very much out. In our center, in my personal practice and belief, I don't believe in first event or your incident procedure to include a stent for the venous system. And I've seen a good amount of compression. So when we look at May-Thurner, which is really a compression disease that we talk about, it has a huge spectrum with the end kind of consequences of these, of forming these webs that are very intricate with multiple tiny perforations in them. And in that kind of context, I've had a patient who had a web noted on their initial DVT that I evaluated with ultrasound. And after doing that, I did ClotTriever. We opened up that web clearly, because we opened up, ripped that web open by doing the ClotTriever itself. And I said, you have this, you're very likely that you have this iliac compression situation, but you've never had a clot before. This is your index clot. And it's very difficult to do a stint on an index clot, in my personal opinion. So what I do is I treat it, put them on anticoagulation, tell them if they have failure on anticoagulation, we need to revisit this and talk about a venous stent. This patient now is 2.5 years in, no further clot, and I see them every 6 months. So at that point, I can't tell you that even if you truly have compression with traditional sequelae, such as significant web development, that you necessarily need a stent. I understand the alternative too, that you're trying to prevent a future index event and such, or future significant event. But for me in my practice, as well as our center's practice that we've kind of protocolized together with me and my partners, we've kind of said that on the index event of an initial clot without significant prior clot history, we're not going to consider a venous stent. We might evaluate with ultrasound for future reference, but not put in a stent unless we absolutely have to.
Definitely, that's very helpful. Well, Manoj, thanks so much for your time and for your expertise, and definitely it was a very comprehensive review of VTE management, catheter-based as well as stent-based therapy for patients with DVT. Please watch these videos and others on CVI YouTube channel. This is Shadi Reis from Austin. Thank you so much for being with us.